Hi, my name is KMoore, and for my Capstone project, I have chose to discuss the need for a further understanding of do not resuscitate orders. My current area of practice is med-surg. However, I did my preceptor hours in the emergency department, where it is a completely different atmosphere. Emergencies happen every day, and people come in, and it's very important that the nurses know how to treat the patient and what the patient wants. And I have seen personally that the ER staff are not quite as familiar with DNRs on how to obtain them and how to properly follow them as what the staff on med-surg seems to be. Therefore, I chose to do some research, pull some articles, and further discuss this issue with that staff. This came from the confusion and the questions around the legalities and the formalities of properly obtaining and following DNRs. It is very important that healthcare staff feel comfortable and competent with this type of issue because it is a means of communication for the patient regarding their wishes about their own personal care and treatment. It guides the providers in what to do in emergency situations and end-of-life care, which could happen in the emergency room or once the patient has been admitted to the floor. Either floor. It only becomes an issue when providers are uneducated about it, and it influences decisions regarding orders for life-sustaining treatments rather than end-of-life care. Since the emergency department is often the first area the patient is seen and can be the most critical, I saw the need for further understanding of the DNR orders with this group of professionals. I feel that more detailed education should begin in the nursing programs prior to graduation. This would coincide with the Quality and Safety Education for Nursing project, which has plans for enhancing nurse educators' focus on safety and quality in healthcare along with increasing safety and quality awareness by providing a foundation for evaluation and continual process improvement in new nurses. Which leads me to my next point. Not only should it begin in nursing school, but the facilities should do continued education regarding these as well because it directly impacts patient care. Many nurses, experienced and unexperienced, often do not have a good understanding of what a DNR order is and how to communicate with the physician, the patient, and family regarding obtaining and following one once it is in place. If it were better covered in nursing curriculum, nurses would be more familiar and comfortable with them in practice. The desired outcome is true patient-centered care, which honors the whole person and family and respects individual values and choices. Not everyone will want everything done as others will. It is very individualized and should be a patient-to-patient case and scenario. This can only be achieved also by high-quality knowledge, skills, and attitudes of all department staff involved. If the nurses are uneducated about the issue or just not familiar with the process, it may give them a negative attitude, which could influence the family or the patient. It needs to be very unbiased when discussed. Therefore, my hope is that by providing the department with more literature to read and reviewing the subject in general, I think that the staff will provide knowledge and familiarity and comfort level that will lead to holistic, high-quality care. When I reviewed the literature, I found several things that discuss the perceptions of and actualities of DNR orders, which can differ. When related to plans of care and initiation or withholding of treatments in the hospital setting. The recommendations of this literature were that physicians also be better educated in communication skills necessary to undertake these types of discussions. Not only the nurses, the physicians are very, very important in this decision. KMoore 2013 spoke very highly of teamwork in a setting, that this interrelated knowledge, skills, and abilities to support objectives and missions is a must. I feel like the physician, he is the team leader in a situation. For instance, if you have a code in the emergency room, if the physician is calm and collective and he seems knowledgeable, the staff are more at ease and the entire situation goes well. However, if you can tell that the patient or the physician is not very comfortable in this setting and have not dealt with it very often, you don't have as much trust in him, and it affects everyone as a whole. That's why teamwork is so crucial. The purpose of teamwork is to work off from each other's strengths to achieve the highest outcome. And if the physician is not educated well on the DNRs, then the nurse should be. Smith and O'Neill stated that if available, the use of palliative care consultative teams can also help in engaging this very sensitive discussion. There may also be benefit to adopting the use of combined directives to allow patient preferences to be documented, because as we all know, if it is not documented, it is not done. And it's better to handle this discussion when the patient is able to communicate their wishes rather than waiting to when they are not. Staff should assess if the patient is actively dying, what treatments they could benefit from, and what are realistic goals for this patient, while taking into consideration the opinion of the patient and their personal quality of life. Another resourceful article is by Bishop Brothers Perry and Ahmed, which tells the history of CPR, or cardiopulmonary resuscitation, basic life support, or BLS, and advanced life support, or as we know it better, ACLS. They discuss how previously physicians could do very little when a patient was actively dying, but once these came into place, they could resuscitate them with the developed protocols and procedures. By 1976, as patients and doctors become aware of CPR and its limited usefulness, because it's as anything else, it's not 100%. Papers began to appear arguing that orders not to resuscitate should be an option. By 1994, lists began to emerge categorizing those patients that did not benefit from CPR or ACLS. And eventually, nursing journals would join the questioning of CPR and ACLS with their own data. Another article expresses the need that one should be aware that CPR and ACLS is a medical intervention with reasonable success in some kinds of patients with certain kinds of diseases. But one must remember that CPR and ACLS also has miserable success rates in certain kinds of patients with other kinds of diseases. For instance, an elderly terminal cancer patient may not be a good option to be a full code and receive ACLS if they are on a ventilator or they become unresponsive. Quality of life needs to be taken into consideration with this huge decision. The one article that I read, it said that they preferred the phrase "do not attempt resuscitation" and the abbreviation DNAR, making clear that CPR is really only an attempt at resuscitation. Research said that a DNR order states that cardiopulmonary resuscitation is not to be initiated if the person's heart stops beating or they stop breathing, and that patients may make an advance directive to forego cardiopulmonary resuscitation or other resuscitative efforts. The order may be written by the person's doctor after previously discussing the issue with the person, if possible, or his or her proxy or family member. This is why staff need to be comfortable with addressing one's wishes, because if they wait too long, they may not have the chance to talk directly to the patient, which makes it harder on the families. Especially if it's a large family. Often people have a very hard time agreeing on what is right for that family member. The DNR decisions are difficult and complex, but they can also be more an issue in ICUs. I believe that also in emergency departments, because these units have overriding goals of sustaining the lives of the most critically ill patients, They think the worst in every situation, and they think, how can they cure the worst? How can they save the worst? Often people are concerned that once a DNR order is written, all treatments will be terminated and levels of care will fall. People want their family to be taken care of, or the patient themselves, of course, wants to be taken care of, and no one wants to think that they have been given up on. ICUs often tend to be reluctant to take up one of their beds with the patient who has a DNR order to make the best use of limited resources. This is something I have personally seen with my own two eyes, and I believe it is something to take into consideration when you are trying to make that decision. One article stated that research in ICUs has shown that DNR orders were associated with medical versus surgical admission, white race, older age, being unmarried, the presence of an adult child as a surrogate decision maker, perceived inability to survive discharge from intensive care, and longer lengths of stay. Research in skilled nursing facilities has found that presence of a DNR order was associated with older age, white race, a longer length of stay, geographic location, physician-family member discussion, and presence of an advance directive in the medical chart. However, little is known about the factors associated with having a DNR within the last weeks, days, or hours in other acute care settings. After speaking with and addressing the current knowledge and comfort level of the emergency room staff at the hospital in which I am completing my hours, I determined that there was a need to further discuss and educate them on this treatment and this type of order. They need to feel at ease with bringing up the conversation with the patient and their family, and they need to know how to approach it and how to explain it, how to be able to answer questions when asked, and then know exactly how to do what they should do once the DNR order is in place. It is also important to separate one's own opinion from the situation and not to personally influence the decision of another individual. Some articles stated that often that staff has witnessed techniques of bullying patients to choose to become a DNR. This is not right in any situation. Patients should be given honest facts and honest predicted outcomes. Patients have even reported being badgered to discuss code status or to accept the no code status. Working in a hospital, I do understand that it's very important to know a code status of a patient. However, I also feel that it's important to give the patient and the family plenty of time and information and room to make that decision. And if something were to happen in the meantime, then you deal with it the best you can. But badgering is definitely not a good patient-centered care technique. No one wants to feel like they are being pushed into any situation. Certainly a situation to withdraw care or not to be saved if they stop breathing. Patients and their families need to feel like they are well informed, along with being supported when it comes to such important decisions. Physicians sometimes are not good judges of what patients consider an acceptable quality of life. The outcome most important to patients in end-of-life decisions. Therefore, it is even more important, as I said before, for nurses to be well prepared for these situations and ready to intervene and assist if needed. So then my objective was to review copies of all articles I've found during this project of research with interested staff members and answer any questions that they had to the best of my knowledge. If there was something that I could not answer, then I would do more research or I would discuss it with the physician. And including the physician was definitely in my plan as well because, like I said earlier, they are the team leader. We need to support them, they need to support us, and we all need to support the patient. I can reevaluate this project in the future as I work because I being on the med-surg department, I interact often with the emergency room. My conclusion was I discovered some very interesting views and information on DNR orders, along with what happens following them, and I believe that all nurses need more education, both while in school and after graduation. One very eye-opening article about a new doctor who received a referral from the emergency room one night gave new insight to not automatically jump to the conclusion that a patient should be encouraged to be a DNR. A doctor told the story of a lady in her 50s who was treated with untreated stage 4 breast cancer, who was admitted with shortness of breath and appeared to be in congestive heart failure. The new doctor was shocked when the team of more experienced physicians did not push the issue of the patient becoming a DNR. They looked at the situation at hand, and actually this patient could be treated and could be cured from what was acutely going on. So this is just why, this woman, she recovered. She did not become a DNR. They treated her appropriately, and she ended up going home. This is why physicians and facilities, nurses, social workers, pastoral care, everyone who is involved with this decision and this interaction with the patient needs to be familiar with the legal aspects and the proper patient approach with this delicate topic. Attitudes towards DNR orders need to be based on facts and not opinions, and interventions need to occur appropriately. Decisions and changes in nursing activities after implementation of DNRs need to be appropriate as well. There were several good articles that I read, and basically handling a DNR in a correct way can very positively affect the patient. This was both a learning experience for myself as well as the emergency room staff, because I felt like I learned more about the topic, and I felt like in the end they were more comfortable and more educated as well. And I hope that this has been eye-opening for anyone who has read this paper, and that they will be more aware that we need to stick to facts, we need to know the legalities, and we need to support whatever decision that the patient and or their family makes, and focus truly on patient-centered, holistic, high-quality care. Thank you.